Presentation only. I hope all of you are well, and again, thank you for joining us today. Today we have Dr. Fangfang Xing. He's a pain specialist, and he's going to join us live here, talk about some neuromodulation advances. We thought we'd select some of our cases from clinics. This has been a very common phenomenon that we have in clinics now, that patients come with neuromodulation devices in place to try to help their pain. And relative to the spine, that opens up a lot of questions. So along those lines, it's a great privilege to introduce our fellows, and three of our fellows have prepared cases, and we'll start with Dr. Yev Freivert. Yev.
All right, good morning, everyone. I'm Yev Freivert, one of the neurosurgery spine fellows here at Swedish. We'll get started with the first case here. The patient in question is a 65-year-old female who presented with chronic back and neck pain and positional headaches. Patient has a very extensive surgical history with more than 40 surgeries, including more than 20 prior spine procedures. Of note, the patient had a spinal cord stimulator placed 3 years prior, as well as an intrathecal pump, which was placed 6 years prior to the time of presentation. She also carries a diagnosis of arachnoiditis that's been in place for over 10 years. On physical examination, the patient has bilateral hip flexion weakness, relatively mild, 4 out of 5, some right dorsiflexion weakness and right EHL weakness, which are a little bit more profound at 3 out of 5. The patient's sensation and reflexes were grossly normal. SI eliciting techniques did yield some pain, and on examination of the skin, there were multiple well-healed incisions with no evidence of leakage of a CSF or purulence or anything along those lines.
So yeah, 1 second, if I may interrupt you. So arachnoiditis. So speaking as a neurosurgeon, you've seen a lot at UCLA. What does that mean, and how common or uncommon in your personal experience is that when you have like intrathecal pumps or things like that in your neural elements?
So arachnoiditis, I wouldn't say is the most common diagnosis, but we see it relatively frequently. I can't give you a number specifically, but it's not rare. It can happen with any intradural procedure, certainly with intrathecal pumps, but it can also happen with subarachnoid hemorrhage or meningitis. Basically, the idea is that you have some kind of eliciting event, either a surgical procedure or infection or inflammation, that then becomes indolent and slowly progresses over the course of many years. And for some patients that can manifest as a relatively mild set of symptoms, but occasionally in the more severe cases, it can lead to very severely debilitating conditions, complete paralysis, sensory loss, complete loss of bowel bladder function. That's more rare but very devastating when it happens, and frustrating for us as surgeons because there's very little we can do to address it.
Does it ever get better? Have you seen case reports where arachnoiditis kind of just normalizes again, the clumping of nerves vanishes?
Yes, but in those cases, I think there's some debate as to whether or not the diagnosis of arachnoiditis was accurate to begin with. I've personally seen a couple of cases where patients were labeled as having arachnoiditis by radiology, but there wasn't especially clear evidence, and they did improve, and their imaging wasn't very convincing to begin with. So I'm not sure that any strong evidence exists to that effect in the literature.
All right. Sorry for the distraction, but
no
this is such a common radiographic finding, and patients are almost invariably very concerned about that.
Yeah, absolutely. They'll call nerve root clumping, and you have no idea whether that's just normal anatomy. And so going back to the imaging, this is the patient's current hardware. There's a thoracolumbar construct. You can appreciate both the spinal cord stimulator and the pain pump, and then you can see there's also an anterior neck construct as well. On MR, you can appreciate posterior fluid collection. No no obvious area of continuity with the intrathecal space, although there are a few locations where the dura is a little bit thin, so possibly some communication. The patient was taken for hardware revision, bilateral SI fusion. Oh, and I'm sorry, actually, let me step back briefly. There's a CT Milogram that's available that unfortunately is impossible to retrieve from the medical records at this point. And it did show a little bit of contrast tracking along the catheter for the intrathecal pump. The patient was ultimately taken for a hardware revision, bilateral SI fusion, removal of the intrathecal pain pump with dural closure and augmentation, and then subsequent wound closure with plastic surgery. She's currently 2 months post-op with improved but not completely resolved headaches, and it sounds like she also has significant improvement from the mechanical pain potentially associated with SI joint instability. And these are her post-op scans.
So let me ask you a couple of questions. So first of all, we have a hand raised, and Dr. Decompression very alertly pointed out that if there is arachnoiditis present, and let's ask Dr. Xing later about this, if there is arachnoiditis read beforehand, is placement of an intrathecal device a contraindication?
So yes, but it's not a firm contraindication. I've been taught that in those cases, it's just a contraindication for an MIS or percutaneous procedure. If you still want to place the device, open intervention with more direct visualization of the nerve roots is probably a better way to go to avoid inserting either the catheter or just the needle into nerve roots that are immobile.
And what do you know about metrizamide myelograms? Is that something that you've been taught? Do you know what that was?
No, that's not something that not a procedure that I've encountered before.
Yeah, so that was a non-ionic iodine-based radiocontrast agent that was used for myelograms in the past, and that had a strong proclivity towards creating an inflammatory response. So that was one of the common kind of board questions in my era. I think this is kind of gone past its time, but there was a time when the myelogram use had a strong association with radiographic arachnoiditis. So that was clinically relevant for patients later was a less clear issue. So a couple of other questions. So we're seeing, as I said in the beginning, more and more patients with stimulators and pumps and things like that. Is there a rule, or what do we do when they come into the ER and there's a clinical indication for neuroimaging? What can we do? Can we just send them into the MRI scanner? What should we do to kind of troubleshoot that? Modern devices are becoming more and more MRI compatible, but I think the prevalence of incompatible devices is still great enough that until you identify the model number and get formal confirmation that the device is MRI compatible without any reprogramming or putting it in the temporary safe mode, I don't think it's safe to take any patient into the MRI scanner. I think if there's an indication for urgent or emergent imaging, you'll have to do with either a contrasted CT scan or some alternative if the imaging needs to be done immediately. Otherwise, you get in touch with the rep and with the prior surgeons to identify the model of the device. So Dr. Decompression very alertly points out that the crosslink, which yours truly speaking in the microphone right now likes using, can add dead space that can add to CSF leaks. So that's a very appropriate assessment. I feel, and I don't want to sound full of hubris, so confident in my dural repair and augmentation that I'm not too worried about that. And again, I'm sure I'll have a CSF leak later today or tomorrow if I use one. But a lot of surgeons have a worry, and a justified worry, that if you create a cross-link dead space over the dura, this could induce or prevent scarring. Rod, any thoughts on that? Crosslinks, creating a dead space over CSF repairs?
No, I mean, I actually like it because I think if you have to go back, it creates a little barrier. So I personally like using them in revision cases and multi-rod constructs.
And to Dr. Uday Gupta, your question was, in this patient, were the CSF, was the headache situation was clearly positional due to CSF leaks? Yes, the Milogram that we could not download this morning, frustratingly, clearly shows a substantial ongoing leak. It was contained, but the patient over a observation period of like 6 months had recalcitrant headaches, and she actually had them much longer than that, but the Milogram showed a very clear, pretty sizable pooling, which we were surprised about. So yes. And again, greetings to Dr. Harshad Parekh from Mumbai. Glad to have you on board today. So any learning points from your end, Yev, as you looked at this case, and I think you also helped very capably repair the dura on this patient?
No, I think we touched on the majority of the points. I think the most critical point in this case was identifying the SI joints as the main source of mechanical pain. Sometimes that's something that we overlook. It seems like in her case that was the key portion of the procedure.
Yeah, we did a formal SI joint fusion on her from posterior, so with bone graft. Great. So yeah, these pumps and stimulators are a little bit of an issue for us in clinical medicine. And again, having both in place was a question asked by one of our other colleagues. How common do we see that? Is that something that you've seen a lot in LA when you're training there?
It's relatively rare, and I think seeing a patient with both of those devices in place certainly raises some red flags. Typically both of those interventions are kind of late stage. So if someone has arrived at the point where they require both, you probably want to think twice before offering further intervention, at least until you get a very thorough history and perhaps observe the patient over the course of several months to make sure that all of the symptoms make sense.
Great. And you had one more case prepared?
Yeah, this is just a quick case. Recent case that we did here at Swedish, just clinically interesting. I think that's why we chose to present it. It's a 41-year-old male presenting with 1 week of neck pain and swelling, as well as bilateral, relatively mild radiating arm pain. The patient had a history of C-spine osteo in 1998 and was fused in a non-instrumented fashion in another country. He presents relating some painful swallowing and otherwise has no major medical or other history, including IV drug use. On exam, he's full strength in the arms, the legs, doesn't have any objective sensory deficits. His reflexes are normal. He was found to have a couple beats of clonus in each ankle. He has one well-healed right-sided neck incision and has some mild hoarseness on exam. The clinical team taking care of him went through the imaging cascade, first obtaining plain film imaging, which shows a little bit more prevertebral soft tissue than you would typically expect, and you can appreciate the non-instrumented fusion there. On CT imaging, again, there's a pretty decent amount of prevertebral tissue than what you would typically see. And you can appreciate perhaps a little bit of erosion of the bone, although it's unclear if that's just how it looks after his initial surgery many years ago. We don't have any other imaging to compare to. And then finally, we have an MRI demonstrating pretty substantial involvement of both the prior fusion as well as the prevertebral tissue. No clear abscess or other loculations, although radiology was suspicious about a few very small locations. The patient was admitted for antibiotics with ID and internal medicine managing the patient's care. But after 3 days, he felt subjectively worse and on formal examination was noted to be more hoarse. He was upgraded to ICU status. This MRI on the right side was obtained, now demonstrating formal abscess right here that you can appreciate on the imaging, and then he deteriorated further and was taken to the OR for emergent nasotracheal intubation, and at the same time, we on the spine team and ENT were consulted for operative intervention to evacuate the abscess and debride any other abnormal tissue. Surgery was successful. Patient's currently post-op day 5, extubated, was recently transferred to the ward and is progressively regaining his swallow function and his voice.
So we thought we'd show this case because of a number of factors. This is not my patient, but a pretty normal, relatively young man, right? I mean, so we don't have any immediate risk factors for an infection. And he had a remote history of a anterior cervical fusion.
1998.
And there's no hardware in there, right? This is just bone graft, right?
Yeah, no.
And it looks solidly healed. There's a question of erosion.
Yeah.
So how did he get infected? What was that?
So yeah, that's something that we debated extensively. I mean, my personal favorite theory is that once you have a postoperative site, it's going to be relatively immunosusceptible. The vasculature isn't going to be completely normal. The bone won't be getting routine perfusion. All the tissue, the scar tissue that was resultant from the prior procedure, will be somewhat abnormal and more prone to seeding. Everybody occasionally gets bacteremia, when you brush your teeth or from multiple possible causes. So the bacteria are a little bit more likely to land in postoperative sites. Another interesting possibility is that there is perhaps an occult, very, very small esophageal injury or something along those lines that could be seeding the area. And very, very, very slightly. And after 20 plus years, it just manifested finally.
Yeah. Rod,
I mean, what's interesting is the patient had a very high incision and he developed a hypoglossal injury and couldn't swallow for like 2 years. So I think, my suspicion is there must be some little fistula or tract or diverticula. They got maybe a little food or something, or just got infected, and that's what seeded it. That's probably more likely.
Yeah, we have great questions. So, first of all, what was the bacterium that was found?
I think it's MSSA, if I'm not mistaken.
So not a typical oropharyngeal etiology. And one of our colleagues, Dr. Parek, asked if this could be TB. This is a great question, by the way.
It could be, but we did send cultures and nothing has grown out so far, although TB is very slowly growing. So it's possible that they'll detect something later.
And again, the surgery was done in 1998 in Europe somewhere, right? So he had no other spine surgery since then. Yeah, so it's interesting. And ENT was obviously consulted beforehand, and they looked down the esophagus. They did an assessment.
Yes.
Yeah. So Dr. Dekotowski asked him, absolutely, Mark, in this kind of a case with an upper pharyngeal area problem, you want to have ENT around also for possible airway access. And Dr. Shah asked a great question. When you go back to the initial image, why was this not drained right away? Very legitimate question. So in that first MRI, when he was just admitted, why was this not drained?
There was nothing to drain. There's no fluid pocket.
Yeah. Rod, in retrospect, I know you weren't consulted for this at the time. We were always taught in my residency, retropharyngeal abscesses, I think that's a board thing, are a surgical indication and can be a surgical emergency. So when do you drain a patient when they have a retropharyngeal fluid collection?
I mean, usually this is an area that's quite accessible via ENT. And typically it's managed by the ENT surgeon. So we don't really see a lot of them. Usually, again, unless they've got some epidural abscess component, we don't really manage the retropharyngeal part. But I think in this case, we got involved because of the fact that there was this remote history of the fusion.
And again, Dr. Dillon asks, what was the causes of voice hoarseness after initial surgery?
So that's what Dr. Escuyen mentioned. We don't have a clear history and obviously no access to the records from 1998 in Europe, but it sounds like maybe there was a little bit of a misadventure with some of the cranial nerves. At presentation, the patient, actually, I'm sorry. Can you repeat the question? You mean?
So Dr. Dillon asked, why was the patient hoarse after that first surgery?
Oh, after the So we think it's likely something that happened with the initial procedure, some kind of nerve damage, but we don't know for sure.
Yeah, no, that's the best thought. So if you go forward to the CT, one question that I had, and I want to hear what Dr. Escuyen thinks is, we debated that there's probably some osteomyelitis there in the old fusion zone. What are you going to do about that? And how did you decide to not resect that area just to be on the safe side since you were there?
I mean, we looked at it and it was solid. There wasn't really, it was just a walled off abscess in the longus coli and the prevertebral, edema was quite significant, but we didn't see anything, draining that needed to be drilled out or anything like that.
Because I don't know what to think of that. If I look at that sagittal cut, it looks like there's erosion going on. And if you look at the MRI scan, that second MRI scan after he'd been admitted and put on antibiotics, it looks to me like there's an active process in there with a sequestrum probably. Can you put the cursor onto that dark triangle in that posterior area? So that's not accessible from the front. So I personally think that this man is not out of trouble yet and may require further things. But I think clearly the life-saving surgery was done the first approach.
To be continued.
To be continued. But again, this case shows that patients are very susceptible, and we're joined by Dr. Xing now. Good morning, Fangfang. Thanks for joining us. And we showed a stimulator first with ongoing, actually a patient with dual PAC, a patient had a dorsal column stimulator and an intrathecal pump who had an ongoing CSF leak. And this patient has no stimulator in, but it just shows how patients can be susceptible to infections later on. And any other learning points from this for you as you review this case, Yev?
No, I was happy to assist in his care, and then we were able to get him out of trouble, at least in the short term. But I think it's a very fair point that now that the bone is involved, if the antibiotics don't work, we'll be back there again, probably relatively soon.
All right. Thank you, Yev.
No problem.
And next we have Dr. Zach Tatarin, and he has another interesting case. So good morning, Zach.
Good morning.
And yes, we should look at postoperative dysphagia and various factors for it in the future, Rod. Thank you, Mark, for your suggestions. And Dr. Dillon points out recurrent laryngeal nerve irritation is unlikely in upper cervical abscess. So good point. Good morning, Zach.
Good morning. I'm Zach, neurosurgery spine fellow here at Swedish. Currently on Dr. Chapman's service, and this is a patient we operated on last week, or 2 weeks ago, sorry. So this is a reliable 62-year-old female special ed teacher. Unfortunately, had scoliosis surgery at the age of 19, resulting in multiple complex revision surgeries. And she had a catastrophic surgery 24 years ago, which left her with severe bilateral lower extremity weakness, numbness, and a neurogenic bowel and bladder. She presents with not acutely worsening, but 4 to 6 weeks of worsening lower extremity numbness and weakness, as well as bilateral, pretty severe radicular leg pains. Of note, she has a thoracic spinal cord stimulator and a lumbar intrathecal pain pump, which gives her intrathecal opiates. It's not for baclofen. As stated, 6 weeks of worsening lower extremity numbness, weakness. Also had some fevers, night sweats, type symptoms, which made us concerned for infection. ESR was slightly elevated, CRP slightly elevated, white blood cell count was within normal limits. This is her exam on admission, which shows the bilateral lower extremity weakness, which is hard to discern from her baseline, but she says she subjectively feels weaker. So because her pumps were placed, or her pump was placed quite a while ago, as well as her spinal cord stimulator, they were apparently not MRI compatible. We proceeded with full spinal.
Can I interrupt you there?
Yep.
So we have, can you pass the microphone on?
Yeah.
So Dr. Xing, this is a case dissimilar to the previous one we showed. So we previously showed a patient who had a dorsal column stimulator and an intrathecal pump. And the first question we have is when patients develop trouble, when can we get an MRI scan? How in the heat of the battle can an ER doctor decide whether this is an MRI compatible device or not?
Oh, great. I mean, it really depends on the company that we're using and also when they produce their product. So it's a very industry driven type of standard. And so I'd say the current modern simulators implanted in the last 3 to 4 years, Abbott, Medtronic, Nevro, these companies are all MRI compatible. The ones that are increasingly more so are in the Boston. And I'd say prior to 5 years, I mean, we have to really go back to the manufacturer to understand if they're MRI compatible. Keep in mind, these devices are never fully MRI compatible. So some are 1.5, some are 3, some are even lower. So we have to kind of ask the company on a case by case basis, when they're MRI compatible, which is challenging. And so one thing is each of these patients carry a card. I know in the middle of the night when we're in an emergency situation, we don't want to be calling 1-800 numbers, but they tend to be pretty accessible.
Good, thank you for that answer. Do they have to be turned off when the patients go into the scanner?
Yeah, they do. So every company is different, but some of them have an MRI compatibility mode that allows them to still receive spinal cord stimulation. And some of them just need to be turned off completely.
Okay, and the patients should have those control units with them.
Ideally, yes.
All right. So this was a patient where just on the time factor, the chronologic factor, it was unlikely that they're going to be MRI compatible.
Yeah,
So,
I mean, her placement of her pain pump was in 2016, and the spinal cord stimulator was years before that. So she was under the impression she was told they were not MRI compatible. So we proceeded with a Milogram. This is her thoracic Milogram. She had 2 areas of problems. You can see her spinal cord the middle image is a coronal. You can see the spinal cord stimulator rostral to the more caudal. How do I do the cursor? There we go. So, oh my goodness. All right. Spinal cord stimulator. Oh my God. Intrathecal pain pump. Contrast, no contrast. So that's the coronal of her thoracic contrast cutoff. That's the sagittal. This is her lumbar imaging.
and I want to just point out, none of these surgeries were performed here at this institution. This is
Yes.
what the patient presented with in the middle of the night.
Yeah, this is our first meeting, first encounter. This is her lumbar imaging. So she has another area of contrast cutoff here and here on the coronal. So we proceeded to take her to the end. Oh, of note, an important part of this history is, given some of her symptomatic complaints, we were concerned about a possible infection. And we broached the possibility of, were we to find pus, because we don't have an MRI to confirm or deny the presence of, were we to find an infection, we would normally proceed with removing the pump that was contiguous with the infection. And she was adamantly clear that she was so reliant on the benefits of both pumps that she didn't want us to remove them, even if they were infected. So we proceeded to do a decompression.
So let me ask you one question. So if you go back a little bit, Rod, if you can share microphones, please, with listening with Dr. Xing. So what happens there? What do you think went on? So neurologically, her status was really difficult to differentiate. She had a clear thoracic sensory level. She had preserved motor functionality. She had a chronic incomplete cord injury during one of the deformity surgeries from an outside institution. And then she has this weird stenosis down there. So what are your thoughts in terms of what happened there? The stimulator, so there are two probably different processes going on between the thoracic paddles on top and then that lumbar spine there. There are two significant obstructions. What happened there? Or what do you think of as a surgeon?
I mean, I think this is the natural history of, someone that probably has an unrecognized, maybe, does she have rheumatoid arthritis? Or?
Yeah.
And she had just fusions and scoliosis, right?
Yeah.
Did she have RA?
I think she did, to be honest.
Okay, wow.
Yeah.
Okay.
Yeah, so I mean, I've seen this, and again, historically, when they do these corrective surgeries, usually there's some inner bodies there, but I've seen, obviously, the bone can grow back in those areas, and probably between the RA and the robust fusion and the progression of her deformity is probably what's kind of pushed her over. And it looks like she's got almost like a camptocormia developing.
She actually has a reasonable posture. So a couple of thoughts for Dr. Dillon. Great question. Myelogram. In this setting, our radiologists do these, obviously, and we do a lumbar puncture only. Great point by Dr. Dillon also, is a myelogram not contraindicated if an infection is suspected. Of course, if we have a clear suspicion of an infection, we would really second guess that. In this situation, we did not have a mass effect, but we had to contemplate that there was an epidural infection. But the puncture site is below that. So they usually puncture at around S1-2 or L5-S1. In this patient, again, we have so many surgical complex patients. Our neuroradiologists are very trained in doing basically a sacral access point. and then tilt the patient so that the dye goes. Very rarely do they do a C1, C2 puncture, but I'd say probably 1 in 20 is what I gathered from the other day. But this was all done and accessed through a lumbar puncture. Sometimes if you have no dye migration, they will do a second puncture. Do you remember whether they did a second puncture on this patient?
I don't think that they did.
Yeah. So we have two processes going on. Dr. Xing, any other questions about or thoughts from your end? He has a microphone now. What happened with that thoracic paddle situation? Why were there two thoracic paddles and then there's a stenosis between there? And any thoughts on that lumbar development around the intrathecal pump?
Yeah, I mean, gosh, I'm going to be presenting a little bit about some of the opportunities of spinal cord stimulation. Just seems to be a nuisance for everyone in this room here. The dual paddles here. I mean, there's a possibility that we're differentially. I mean, I don't know what the thinking is behind the implantation, but sometimes two devices are used. Are there two paddles in there?
Yeah, there are two paddles in the thoracic.
Yeah, and sometimes there's a differential recruitment of neurons that we'll talk about in the presentation for different pain patterns. And the placement of these leads depends on kind of the segmental sort of location of a patient's pain. So that's the only conceivable thing that I can think of. The other component here is maybe one of the paddles migrated and a second paddle lead was implanted because of that migration.
Great. Okay, what do we do, Zach?
So we addressed both problem levels. These are intraoperative shots of the thoracic laminectomy site. So it was essentially we just had to locate on a radiograph the area in between the two paddles. And I think our next presenter, Dr. Cook, did an expert thoracic decompression of the thoracic problem spot as I tackled the lumbar problem spot. And this is the area of decompression between instrument area of decompression. And that was where her cutoff was. She was very tight at her thoracic level. And she was also she had a rim of normal bone up here, a rim of normal bone down here. And we just had to find the edges and scrape everything off and then undermine a lot of this overgrown fusion mass, which seemed to have been digging pretty harshly into her thecal sac. And these are the post-op imaging. This is our thoracic decompression site, lumbar decompression site. Patient's symptoms were greatly improved post-operatively. And just because I went into a rabbit hole of reading papers about spinal cord stimulators, and we're not totally poo-pooing them, I found this good article which showed how patients with failed back surgery syndrome, as well as CPRS, both seem to be very satisfied with the beneficial results of their intrathecal pain pumps and spinal cord stimulators in regards to their opiate requirements pre and post-operatively. So,
and Dr. Xing, we actually go back on this patient was so happy with her stimulators that despite our counseling that we asked for a conditional permission to remove them in case of an infection because we couldn't rule that out, she refused that. She explicitly actually in signature stated that she wanted them to stay in there against medical advice.
Definitely against medical advice.
So we had no intentions of taking them out, but we said we have to be prepared for that. And so I thought it's actually nice to see. I mean, she really benefited from that. She lives independently. She's a very strong woman. And she liked them. And again, when I see these dual stimulators, my small hairs in my back of my neck raise, but she actually had a very constructive relationship with them both. And she felt she could, in a differential fashion, identify the merits of both the intrathecal opiate use and of the stimulation. One other trick, any thoughts on how to avoid injury to the catheters and to the leads when you do a dissection or vision dissection in these patients?
I think they're pretty resilient to Bovie dissection along the course of them, kind of like a VP shunt in a neurosurgical case. You can Bovie along the course. And then as you're approaching areas of thecal danger, you can do a more blunt dissection. But obviously, try and locate it on C-arms preoperatively so you're not timing your incision with the catheter. And minimize blunt dissection. I think Bovie dissection is safe. So
great. Thank you. Great case. Any thoughts, Rod?
No, I mean, I think this was an excellent presentation of what can happen even after a fusion.
Yeah.
and patients who have progressive deformities that's not treated. How high did you guys go up to?
We did two separate incisions, two dissections. I think one was roughly, correct me if I'm wrong, T7, Jared, was that T7 to T10? We localized
Just
through
did a
leads.
Lamy?
Yeah, small
No
laminectomies,
fusion.
no hardware.
I
Everything
think
was
it's-
fused. Everything was
Yeah, it's
fused.
beautiful.
And
very well
then
done.
we did a L3 to L5.
And she did
revision
well
on
after
it, and she
surgery.
did extremely well. It was actually very nice to see because, again, when we have patients with longer standing pain management issues, our concerns are always multifocal as to what's driving this patient. And we did not know what we'd encounter. And we simply found heterotopic bone in the neural canal in both places. And we obviously coated the resection sites of the bone with bone wax very diligently. So hopefully this will not regrow. Why it happened in the presence of a completely solid remodeled fusion, I can't tell. But again, our clinical suspicion was leading a kind of an just an opportunistic kind of an infection. And that was seemingly not the case. We also had SED-rate, C-reactive protein and all that. And that was
Do you think that
low.
rod broke and then she fused?
So her surgical history was complicated. She was treated in an outside institution by a surgeon who we know. And there was an intraoperative spinal cord injury.
Oh, wow.
And so then that led to a cataclysm of multiple other surgeries and hardware revisions. But in the end, she was positively fused. The lumbar hardware was left in place after the thoracic hardware had been removed. So it's a little bit complicated. There were multiple surgeries involved, but she was left with a relatively functional, incomplete spinal cord injury status that then declined, and she was independently living. So she's actually working and independently living. Very tough woman, and very, very grateful. I mean, it was so nice to see. It's like a dream come true. Like a day or two later, walking around again when she had been basically immobilized. So
I do have one comment on preserving the catheters, the leads. So one thing that I did in that thoracic region was there were anchor sutures that were essentially holding the wires directly in our way. So just severed the anchor sutures, made sure that there was enough slack, and used a blunt wheat liner just to keep them out of the way, and then just re-anchored on the way out. So manipulating was okay.
Yeah, that was a good point. I had a question for the panelist here. That is there any special precautions we should be taking when bovying or dissecting near these when patients want to keep them in place, or when they're intrathecal versus epidural or something like that?
I mean, I think like most, I think you just have to be cautious. I think, a bovie on a low setting, and I think it's safer, especially if you know that those paddles are sitting on the cord. So I think you just have to be careful.
great.
I went sharp with a buffer
And
of scar.
Dr. Ifanullah Shah has a great question. I'll ask Dr. Xing about that. Can we do neuromonitoring when patients have these stimulators in place?
Yeah, absolutely.
So motor evokes?
Yeah.
No problem.
Yeah.
Do we have to turn them off beforehand?
Oh, absolutely. Yes.
Absolutely, yes.
I mean, right now, we'll talk a little bit about technologies, but some new technologies are going to use ECAP to actually alter the type of modulation the spine gets. So we're going to be encouraging that practice down the road.
Great. Okay, Jared, your case, and then we have our guest lecturer here.
Okay, this one will be nice and quick. This is a 53-year-old female that presented with bilateral lower extremity pain, numbness, weakness, some instability in her gait, worsening bowel bladder dysfunction. She'd been ambulating with a cane for multiple months at this point. She previously had a spinal cord stimulator that she said was ineffective to kind of play into indications, for this during the spinal cord stimulator trial. She said that it greatly helped her pain, but after it was removed, she said it was really about 15-20% of her pain was resolved at best. So not a great indication to have it put in. And past medical history, diabetes, fibromyalgia, obstructive sleep apnea, cardiac, and the surgery in her surgical history, just the stimulator implantation in the mid-thoracic spine, C1 to T2 laminectomy and fusion prior. So the neurologic exam, did show some deficits, some hip flexion and ankle weakness, and this is when she had the stimulator in previously, that was important to see that, because that is where we found at presentation, she had a large calcification that was in that area, and that was compressive. So when she first came in, she had that stimulator. It was removed so she could get an MRI, because also it wasn't working. And we were able to see this on CT, this calcification that could represent compression, and then you can see exactly where it is on that MRI, on both the sagittal and axial cuts here. And so this posterior problem causing myelopathy, we addressed it posteriorly with just a simple T910 laminectomy, decompression of that hypertrophic calcified tissue. And since then, she's been doing significantly better, especially in that gait and bowel and bladder sense. So, we have seen that there have been complications with spinal cord stimulators that have been documented. A lot of them related to hematomas, epidural fibrosis, sometimes myelopathy if they're placed in an already stenotic area, infections. I hadn't seen anything about calcification, but I know that some of these entities could lead to calcifications in the chronic setting. So it's a possible etiology of that.
That's a very interesting case. Thanks for sharing that. Can you go back again to that CT scan? So this is below the lead, is that right?
It's right where the lead was.
So it's in the area of the lead. So this is a implant-related hyperostosis?
That's our theory. Obviously, we can't say definitively that that's what caused it, but that is the going thought.
Rod, so what are your thoughts? I mean, this is your patient. This is a great case.
There's a little bit more to the history, but she had pretty progressive cervical myelopathy. And so this is one where, the patient after surgery got better and then she got worse. And that's why we re-imaged her. But, sometimes you see these granulomas with intrathecal pumps, but I've never seen one with a stimulator. And you can see, go back to the one image where the stimulator was in, you really couldn't see it that well. Before it was removed. And so we just kind of clinically, she went downhill pretty quickly. And you could see on the MR, she's got T2 cord signal change. It's hard to see it there, but she got better immediately after surgery.
And on that original CT, there is that scatter artifact, but you can see where that that calcification is. It is around the lead.
So we have an expert here, Dr. Xing. So is this something that you've heard of or learned, seen as case reports?
Yeah, I mean, no. Yeah, so it's interestingly, obviously this is a paddle lead. And so the explosion of the utilization of this device within our field is mostly with percutaneous leads at this point. And so it'd be interesting to see if certain types of, the instrument itself actually contributes to the development of this. But I've never seen this, to be honest. This is the type of insight that actually helps practice for individuals like myself moving forward and considering something like a spinal cord stimulator for patients. And certainly, I mean, I'd love to see this published and just to tell everybody this can happen. Yeah.
Yeah, we've not seen this, so I was really keen when Dr. Laskuyan brought this up. Did you put any bone wax in there, something to prevent heterotopic ossification? Did you put on indomethacin? Or?
Yeah, no, we waxed like crazy and did wide laminectomies. So
what about pharmacologic inducement?
Not really. I mean,
like that?
No. I mean, I just think it was probably related. It wasn't calcified. It was more
a calcific granuloma.
Yeah, I mean, it was more granulomatous type of lesion.
Because she does form bone with it, so she has some early inklings of dish in the lower spine. So this is a little bit of an arthropathy kind of a patient who has a hyperostotic arthropathy pattern, but not prohibitively so. I found that was a very interesting case. And the other question I'd have as a surgeon would be, what are your thoughts about the dural integrity? When I see hyperostosis around the dura, I'm always worried about dural atrophy.
I mean, the dura was fine. I think, again, one of the things, anytime you have a patient you operate on is just to re-image them, because it's easily, we did CT after MRI of the cervical spine, lumbar spine. And only when she started to have progressive leg symptoms that we got a thoracic MRI.
So Dr. Dillon asked some very good questions. And again, as you've heard, Dr. Dillon, none of us have seen this heterotopic ossification around paddles. We don't know what this was caused by. We assume this is a calcifying granuloma. It was obviously sent off from microbiology, which is negative. A really other important question from one of the other participants, I thank you all for your chat, by the way, it's great, is tips and tricks for reoperation. I highly recommend studying your CT scans very carefully. So we actually make a drawn out chart that we hang from our OR table that basically identifies levels and identifies exactly cables or leads and where they enter, left, right. And we visualize those also then with C-arms so we know kind of what to expect. So you should not do a search and explore surgery. We call it a Columbus surgery. When you have these patients, you should have a very clear understanding what's going on. And this is clearly not a patient where you wreck around with a Cobb elevator. You have to kind of use electrocautery, as I think several of our colleagues have now identified. And once you see them, then you localize them, you trace them along with electrocautery. And of course, as Dr. Xing has pointed out before, you want to be very careful about making sure they're turned off and that the patients know what's going on. So that was that. Dr. Dekutowski points out, thank you for all your comments, Mark. There are multiple different bone wax types, and some can actually induce inflammatory responses. So that's correct. Now, again, I'm just a simple orthopedic surgeon in that regard. I have not found that to be the case, and that's a totally empirical statement, but I was taught to use that when I resected large heterotopic ossifications and pelvis fractures, and it did not seem to cause any major problems. But histologically, I'm sure you're potentially right. So caveat noted and all that. It's better than anything else that I know that I have available right now. So any learning points for you, Dr. Cook, about this case? Any thoughts?
I think everything really has been stated there. I would like to reemphasize that when you see things like this, just assuming that there is there's some friable dura underneath or dural erosion is probably the best idea. Thankfully for us, it was not. Just keep in mind that that's probably going on, or very well could be going on into that.
Super. All right. We're a couple of minutes early for our guest speaker, and it's great to have you here, Dr. Fangfang Xing. I'm going to step up front to introduce you whilst you get your laptop ready. Yeah. Dr. Fangfang Xing is a faculty here at Swedish, and he is in our integrated pain service clinic. He is a board certified anesthesiologist and pain medicine specialist. We'll fold this up and turn this to the side. And you find a cable that you like here.
Perfect. Ben
is otherwise coming with a different cable.
Okay, thanks.
He's not using an Apple. Let the record
I know, that's right.
He is a board certified anesthesiologist and pain medicine specialist. He's been a great addition here. And he did his residency medical school at the University of California in San Francisco, and his anesthesiology training at Mass General. So this is a phenomenal background. And his fellowship was in Boston as well at the Brigham, and near and dear to my heart. And he likes neuromodulation and, again, interventional pain management and cancer pain management. And he's been a great addition here to our faculty and helps us with many patients. So nice to have you here, and tell us what's new in neuromodulation.
Great. All right. Well, I really appreciate the opportunity to be here. And I just want to also thank the team here for all of your extraordinary care of spine as well as brain patients. I know we really bank on, rely on your expertise for the care of the patients in our city and also our region. So I want to really kind of send my gratitude and appreciation to everybody in this room that helps care for our patients. So today I'm going to, let me see, I just want to make sure how much time we got here. Yeah, today I just want to give us an update on neuromodulation, which is a topic that's near and dear to my heart, as well as give a little review for spinal cord stimulation, specifically up in the cervical spine. I think in general, this is a pretty young field with a lot of research going into it. And so, a lot of the things that we talk about now is going to maybe bring us back to our medical school days, just to remind us about how much of we've come in terms of understanding of neurobiology and how we can use therapeutic neuromodulation for the treatment of chronic painful diseases. See here. So I do work in the space of chronic pain. So we're following our patients more on a longitudinal basis, and we're able to see some really interesting perspectives about sort of kind of the human condition. I kind of want to start with this slide here because I think it's kind of reminds us why we kind of maybe entered medicine in the first place and the unique opportunities we have caring for physicians where we do. And so this is Tooth Puller by Caravaggio. I don't know how many people in this room have seen it before. Nice Italian painter. And I think this is a really terrific slide drawing here because it really tells us about kind of the subjective and personal nature of suffering with pain. And, for our patients is predominantly spinal pain. And what's interesting to note here is that, our kind of interpretation of pain really depends on where we sit and how we view the patient. And you can see here, we've got the man clearly suffering there who's getting his tooth pulled out. And then we have the person, the dentist here, sort of performing this action. And each of them obviously have a very unique perspective in what pain means. And I think we're in a very privileged position here. We can actually see disease of the spine, disease of the brain directly and understand kind of what a patient is going through. Whereas if you can see some of the other spectators here are looking on in admiration, some may be in apathy. You see that man kind of on the right-hand corner there with his knuckle up there. And then it also informs us that pain is, sort of age dependent. If you look very closely on the bottom left corner, there's actually a child who's looking up at this spectacle and kind of giving that interpretation. And so again, I think the point of this slide for me is how we can really empathize with the patient in front of us, how we're in that unique position to be able to do so. All this to say, pain is a very complicated type of phenomenon. There's a whole nervous system that we have to kind of acknowledge here. There's obviously nociception, which we know really quite well, but for that nociceptive signal to become pain, it has to ascend the cord, it has to get to the brain, and it's going to drive its bus around multiple areas of the brain, from the prefrontal cortex, the limbic system, even to visual areas of the brain, to create this experience of pain. And so I think that's a key element here, which is it's an emotional, affective experience generated by the brain. And so, from my perspective, I'm working with patients who have pain on more of a chronic level. So, the Caravaggio painting is really kind of representative of someone who's suffering from acute pain, and we can really see that and really empathize with that. But for some of the patients that, for example, in my practice and in the practice that we see, patients are having that experience of getting their tooth pulled out on a daily basis, and so we call that high impact chronic pain, and they're dealing with this more days of a week than not. And so that requires more of a comprehensive treatment approach, and neuromodulation is one of them. And again, that's something we'll be talking about in this talk. So our learning objectives here are to describe some of the modalities of therapeutic neuromodulation, what it actually means to be tonic, closed loop, burst, differential targeted multiplex programming, high frequency stimulation, and then also kind of understand the evidence base behind cervical spinal cord stimulation. And I'll let you know up front that, we've got prospective studies, heterogeneous patient population being studied, and we're still needing RCT data for it. Electricity is obviously a really impactful part of our life at the turn of the 19th century, with Faraday sort of discovering sort of electrical properties. It really started and spurred the electrical revolution culturally, sort of in a point of human history. And so obviously electricity is a really important part of our communication and transportation and our aspects of our daily life. And so the question is, how do we use this type of physical property to the help in medicine? And that's the concept of therapeutic neuromodulation. So neuromodulation is happening all around us as we speak in this room, as our nerves are using electrical activity to create the homeostatic environment to be able to allow our human sort of organelles and organs to function properly. And so therapeutic neuromodulation is the use of neuromodulation to aid in medical treatments, and that is to treat pain, to restore function, to potentially reverse neurological problems. As we know, as everyone in this room knows, neuromodulation is used in all areas of the body, on the sort of cutaneously in the central nervous system, in the DRG, as well as in the brain. And the application of neuromodulation is quite wide and depends on where you apply that stimulus. Just so that everyone's kind of on the same page here, there are really two important tenets of neuromodulation, and they're really quite intuitive. The first is where we apply that electrical signal is incredibly important. There's a difference. When we apply it in the brain versus apply it in the spinal cord, we have a differential effect. And also the way that we stimulate nerves is important. And so that relates to the actual channeling of the electrical current and the properties of that electrical current. And so, when I give this talk to primary care doctors, one of my pet peeves is, well, spinal cord stimulation, just a fancy TENS unit. And obviously that violates both sort of tenets of neuromodulation. Number one, the location is cutaneous, not the spinal cord. And second, the type of stimulation in a TENS unit is low hertz, 5 to 10 hertz, and it's not the same type of field that's created. In pain, most of our anatomic targets are the dorsal column. We'll talk in detail about that. But also there's expanding use in the dorsal root ganglion. And then there is finite, but there is emerging literature that use of stimulation in the brain can also be helpful in painful states. So, this is a graphic that might is near and dear to our hearts here in terms of people who study neuroscience and are part of this field. But, the dorsal column obviously is this sensory as well as proprioceptive network that ascends the cord in dorsal fashion and synapses in the medulla before getting to the brain. And this is really the site of neuromodulation for spinal cord stimulation. And what's, I think, really important to evoke here is that most of our understanding of how this therapy works is kind of phenomenological. We apply electrical current here, patients feel better, end of story. But the truth of the matter is there's a lot more going on here. A lot of mechanisms evoked have been involved, the gate control theory, as we've kind of all heard about, but that really is an oversimplification of what's going on here. And so just to give like a basic introduction here, this is the most basic type of stimulation. We apply this electrode to the dorsal column to try to stimulate some of the large fibers there. And the waveform takes on its own sort of characteristics and morphology. So we have an amplitude, we have a pulse duration, we have a frequency, and that's one of the most basic ones. So when patients are getting tonic stimulation, they're getting a stimulation in a very sort of stereotypical fashion in a 50 to 100 hertz range. Sometimes it goes up to 500 hertz. That variation all depends. And the reason why we alter the variation is because we know that the nervous system doesn't rely on amplitude necessarily in the recruitment of cells for spinal cord stimulation. It really has to do with the duration of firing as well as the frequency of firing that our own sort of innate cells utilize. What's really interesting, we're talking a little bit about sort of electrical action potentials and how to measure that, is when we apply a tonic stimulation, what we're trying to do is we're trying to activate some of those alpha beta nerve bundles in order to stimulate interneurons to decrease the windup and the stimulation from more nociceptive receptors going up to the brain. And when we do so, we can actually measure the evoked compound action potential after the source of stimulation. So what we understand is that when we stimulate the spinal cord, there's a ripple effect that happens, and that ripple effect can be measured and allow us to get real-time feedback in order to modify the stimulation in such a way to really be conducive and optimize the patient's pain condition. This is something that's called closed loop spinal cord stimulation, and something that's really a fascinating and important next step in understanding neuromodulation. And so as people in our audience know, when we do spinal cord stimulation, we tend to stimulate above the level of where we think the lesion is. So for example, we treat a lot of chronic low back pain or leg pain, and those nerves are really synapsing kind of at the lumbar region. And so the question is, why is it that we're targeting sort of more rostral to location of the pain? And the reason is because of the neuroanatomic orientation of these dorsal column fibers. They are going into the dorsal column, and as they ascend the spine, they're going more and more medial. And if we place an electrode at the location of the pain, well, we are getting too much of the dorsal root, and as a result, we're creating a lot of non-specific types of clinical features that are really quite intolerable for patients. So sort of non-specific paresthesia. But if we stimulate rostral to it, we're able to get away from those nerve roots, stimulate more kind of midline, and as a result, we don't get those odd paresthesias. So one of the ways to circumvent kind of the non-specific sort of more painful and unwanted stimulation patterns is to use what's called high frequency stimulation. And this is a really important physiological concept, I think, worth exploring. And so again, instead of stimulating the spine at 50 to 100 hertz, we can actually jack up the frequency to about 5,000, 10,000, anything above about 1,000 hertz will give us this type of phenomenology. And so this is the concept of what's called a Rio base, and this is a Kronaxi curve. And so just for the sake of kind of basics, on the right side hand of that asymptotic curve, we see the phenomenon of paresthesia, and on the left side, we see non-paresthesia. So how excitable a cell is depends on how we stimulate it. And so as you can see on this curve here, we can really drive up the amplitude. And if we were to increase the frequency of stimulation, this allows us to drive that energy deeper into the cord and allows us to recruit different neurons for stimulation without that off-target paresthesia effect. And this kind of has changed our ways to treat patients and provide more of a paresthesia-free based treatment. The next type of stimulation pattern is burst stimulation. This is a way to sort of mimic the natural firings of our neurons within our cord and with our brain. So what's been observed is that, sometimes the way that a neuron communicates is through this sort of rapid succession of firing, followed by a degree of quiescence, followed by another rapid burst of stimulation. And so this type of stimulation pattern, if we were to do some functional MRI studies, potentially stimulating more of the medial pathways up in the brain and up of the limbic system. So we talked about pain as a very, very complex phenomenon, and differential sort of recruitment of neurons with different stimulation patterns may yield a different downstream effect here. Next type of stimulation I'm talking about that's also being widely studied is called differential target multiplexed stimulation. And what this type of stimulation is it's kind of seeing the neuron as one player in the entire context of the milieu of the spinal cord. So as we know that it's not just neurons that we see in the spinal cord, we also see supporting cells like astrocytes and microglia. And, if we look at the research, a lot of sort of propagators for neuropathic pain in chronic fashion is believed to be mediated by this complex interaction within the astrocytes and neurons, specifically microglial activation that promotes a pro-inflammatory state that can lead to chronic neuropathic pain. And so here what we can see is that this is a really good study done just recently by Smith, et cetera, but they basically did a transcriptome analysis. And this is kind of the future. We're moving beyond just electrophysiology. We're moving into molecular biology to understand how spinal cord stimulation works. And what you see here is that we have sort of a panel of pro-inflammatory genes that we know are upregulated or downregulated in a state of quiescence or non-injury. And what this team did is that they performed a laminotomy, they put a paddle lead in, they induced a cervical root injury, and then they sort of applied differential stimulation patterns to see what the transcriptome looks like. And the very left there, you can see mostly the dense red area is prior to SCS in a naive model. And then what we can see is different types of stimulation applied and how that transcriptome is changing depending on the stimulation. And as you can see here with this differential targeted multiplexed treatment, which is basically using different hertz frequency at different locations of the cord to preferentially mobilize microglia and astrocytes, that we can actually see a more of a normalization back to that baseline level of gene expression. So, I mean, it's pretty obvious, but here we've got more red, here this is sort of trying to normalize. And depending on the stimulation, we can see how this transcriptome is modified. The last type of stimulation to talk about is dorsal root ganglion stimulation. This is tenet number one, which is, hey, where we apply that electrode is really important. There isn't much studies about which type of stimulation really matters here. Right now, we're using mostly low frequency stimulation at the dorsal root. Obviously, the dorsal root is a very, very important structure. I mean, in our world, I know that the dorsal root is an unfortunate victim of discs and bone spurs and so forth that we have to deal with. But from a propagation of chronic pain perspective, it really is that nice body of neurotissue that accepts a lot of the afferent signaling that mediates pain. And so we can stimulate this directly in the lumbar, cervical, or thoracic spine to mediate pain, to help treat pain. So I want to give a really quick case here. This is kind of and just checking on the time here. This is just a really, it's a feel-good story from our field, and I think it's worth sort of mentioning to the team here because it kind of captures not only how difficult it is to select for these patients, but possible long-term outcomes as we do see these patients for months, years, and sometimes a lifetime. So this is a 41-year-old lady with a history of base of skull and right arm pain. And she's a mother of two. She's a working individual, and she's developed 3 years of continuous pain. And this happened following hospitalizations for sepsis. And if you just do a quick EPIC filter, you'd see that was on and off opioids. There's 112 emergency encounters, 89 pain management encounters, 9 physiatry encounters, 47 neurosurgery encounters. Basically, it's pretty obvious that she's not functioning and getting in and out of the hospitals for pain. So this is a stir image on the left side, and we can see here that there's a lot of signaling up in the sort of the dens there, C1, C2, and a 2-year difference. You can see how there's kind of sort of chronic changes up there, but you can see there's no instability, there's no frank spinal cord or nerve root compression there, and we have basically a chronic change up high in the cervical area. And so we did a C1, C2 stimulation trial with percutaneous leads, and we stimulated up C1, C2. In the literature, most practitioners are stimulating anywhere between C2 to C4, depending on the patient's pattern of pain. And her trial results were fantastic. She has 75% relief for the trial. One of her functional goals was to be able to cut the nails of sugar gliders. I had no idea what those were until I met her, but these are little rodents who are very cute. And as you can imagine, it's hard to really keep your head still and to be able to do that fine motor functioning when you've got a lot of neck pain that's continuous. Improved sleep, average pain scores went from 7 to 1.5, and she stopped using her buprenorphine, which is her long-term pain medicine treatment. And so, what's really rewarding about this is, we follow these patients long-term, and 6 months post-implant, she sends us, this is not actually her, so this is HIPAA compliant, but she actually was able to start paddleboarding and going camping and living her life. So I think this is just a really fantastic example of some of the opportunities of this technology. And so, this tells us, hey, is this generalizable? Like, how good is this therapy for patients? And I know that oftentimes we talk about how disastrous these devices can be here, especially in conferences like this. And they can obviously are perilous, but also present with opportunity. So in the literature, we know that up to 18% of patients after an anterior discectomy or fusion can continue to experience upper extremity pain, either in the actual neck or in the arms. And we also know that there's chronic headache patterns that can persist even after surgical intervention. Of course, this never happens to any of the surgeons here in this room because we have perfect technique here, but this is kind of the literature reported percentages. So in general, if we look at the role of cervical spinal cord stimulation and the evidence, really we only have single and multi-center prospective studies. We don't have any RCTs. And a lot of the literature about cervical spinal cord stimulation kind of all mixes together both lumbar, thoracic, as well as cervical pain. So you can't really, it's hard to divide away the cervical component. But this is a really good summary of some of the retrospective studies. And you can kind of clearly see how the number of patients that have been studied are really quite low. And retrospective, obviously, there's a whole slew of issues we have to sort of think about in terms of confounding and biases. But if you look at kind of the pain types, there's also a heterogeneous sort of degree of syndromes here. We have intractable migraines, we have neck and upper limb pain, we have Parkinsonian motor disorders. It's very, very sort of a hodgepodge group of patients. And not surprisingly, these published outcomes are favorable. And we'll talk about more about the granularity in just a second. And then in terms of prospective studies for cervical spinal cord stimulation, again, we're really quite limited to very small groups of patients here. Most of these are single center, and again, for a lot of different types of diagnoses. And so again, patient selection is so important, but it's really hard to tease apart how they selected patients in these studies. So just to hone in on one prospective study, which I think is probably one of the better studies out there, but from this one study, we can gain an understanding about the problems with studying spinal cord stimulation in general. This is one that was published in Neurosurgery back in 2020, and it included some of the patients recruited here from Swedish. And so this is the use of high-frequency spinal cord stimulation for the treatment of combined neck and arm pain, and this is a prospective multi-center study. So you can see here how they really wanted to capture a lot of different pain outcomes with the study. They wanted to capture what our subjective pain scores are, but also functional outcomes. And so this is an area that's really interesting, I think, which is how can we get more objective data in terms of how our patients benefit from our therapy? So they include sort of pain disability index, global assessment of functioning, sleep, medication usage, and other sort of quality of life and psychometrics. So this trial included 100 patients who were enrolled, and then 45 were excluded because of screening failure. I think this is a really important component, which is this is oftentimes found when we study neuromodulation, is why are patients excluded? And it really is quite opaque. These are industry-sponsored studies. These are carefully curated and recruited patients to try to demonstrate an efficacy here. And so of the ones that were eventually brought into the trial, 49 were successful and 46 were implanted. Only 3 discontinued because of infection or some sort of patient preference. You can see here that the leads are placed in the dorsal column percutaneously. They thread up to C2, and the stimulation was between C2 to C4. Here's again, just to illustrate the heterogeneity of the population studied. I mean, these are the diagnoses that we were given: radiculopathy, degenerative disc disease, spondylosis, mild or moderate spinal stenosis, other chronic pain, spondylolisthesis. And we know that these terms are kind of non-specific. Who knows what the pain generator actually is for these patients, all right? But all of these patients were all put into the same study, randomized and implanted. You can see here, fortunately, and this is the perspective that you guys are able to offer, seeing some of the complications of spinal cord stimulation. But in terms of the study-related adverse events, I mean, extradural hematoma, medical device site infection, only 1 of the patients had that, and total significant adverse events, only 2. But this is, keep in mind, with percutaneous leads. I don't know what the literature is for paddle leads. So these are the results. And we can see here that clearly we're going to see a response. It's in all published data these days. But we see a change in VAS score that's pretty significant, greater than 50%. And not only that, we see functional improvement as well. So we see here how there's pain relief, but also there's medication changes in terms of opioid utilization. We see this sort of tornado plot here, all the individuals in here, and you can see here that, all sort of close to the upper limit here in terms of pain relief, and it kind of dwindles down to 20% down here for some patients, but the vast majority of patients are kind of in the 60-70% range here. And so some of these observations, as no secret here from what I've been sort of mentioning, is selection is so important because pain is so complex. It's not merely nociception. We have a heterogeneous patient population being studied. SCS candidates are very curated, very selectively. And it really is the individual practitioner who guides kind of who gets spinal cord stimulation, who doesn't. The other challenge is SCS is often thought about as last line therapy for non-surgical patients. So, where we use this therapy in the algorithm, how we treat patients really varies across the board. And then we talked about challenges of capturing some of the outcomes related to pain because of that sort of subjective personal component. Cervical spinal cord stimulation generally lacks RCT data. So we have a lot to understand in terms of basic mechanisms, which patients benefit from spinal cord stimulation, but there's a lot of promise, there's a lot of excitement, there's a lot of basic as well as clinical research in this field. That's it for me. Thank you so much.
Thank you. Virtual applause and real applause.
Any questions?
So before I come across as my usual Jens Chapman critical questions, let me say I believe and see the power of neuromodulation. I want to make that very clear. There are very substantial, just like the feel-good case that you pointed out, very substantial improvement in the quality of patient lives. My question, let me start with this one, is a foundational one, and that is, what I see quite commonly is that patients are offered to do a trial to see, quote, whether it works. And a lot of these folks are pretty desperate. And so how do you kind of avoid this, quote, trial being kind of a selection bias, kind of a lure that basically gets a response modification in the patient just to try to either please the physician or try to move forwards? I find that very difficult to kind of assuage.
That's a really important clinical question that I grapple with on a daily basis. And so, pain is very intersubjective, right? And so what that means is the interaction between two individuals about their pain makes a world of difference. So that's why you hear when patients say, oh, I feel heard and my pain is better. I mean, that's actually a real thing. It's not just a placebo thing. There's an intersubjective psychological component here. And so my sort of private, personal, professional practice is I paint gloom and doom for patients. So during a trial, I say, hey, I want to make sure this absolutely works for you. I want to see functional benefits. There's a lot riding on this trial. We know that placebo effect can be upwards of 30%, maybe even 50%. I do not want a piece of junk in your back 1 year from now that's just sitting there not working. So I know there's a lot riding on this trial, but at the end of the trial, I say, are you okay if this device is 30% less effective 1 year from now? Are you okay? And so for this reason, typically for insurance purposes, practitioners are saying if you get at least a 50% reduction in your pain, we'll go forward. Obviously, 50% is a completely arbitrary number, and everyone's going to give a different response. And to use just that single point to determine the implant is completely, in my mind, misguided. So we're looking at for functional outcomes. Did you sleep longer and how long? What's your sleep efficiency? How much more are you able to walk? Are you okay if this device is not a durable treatment long-term? And so for this reason, what I want to hear from patients is I get 80% better. And I'm okay if this is 50% better in a year or 2 years. And I know that this is not a guaranteed long-term treatment. So that's how I try to personally in my practice select for patients of functional outcomes, as well as sort of patient preparation and anticipatory guidance.
And this is a great segue for a question from Dr. Charanjit Dillon. Thank you, Dr. Dillon. And that is there a plateau effect as far as we know right now of neuromodulation? Does it kind of wane over time?
Yeah, exactly. I think clinically we see that quite a bit, and it usually happens at the 2-year mark. And we think it has to do with neuroplasticity, maybe some scar tissue developing between the leads and the dura, patient positioning, patient's pain pattern changes. And so right now there's a lot of sort of research and thought into, well, how do we trick the nerves with different stimulation frequencies? So maybe they were on maybe a tonic frequency for a while, then we switch it up to a high frequency, then we switch it up to a burst. But that's how we continue to recapture analgesia. But I think the key part of here is that longitudinal follow-up, because a lot of patients may be lost to follow-up and not understand why their device doesn't work and maybe miss a new diagnosis. So the plateau effect is something that's still not perfectly understood, but has to do a combination of neurobiology, but as well as just missing patients who might have new diagnoses.
Super interesting. And then, by the way, please know that Dr. Mark Dekotowski is a very experienced spine surgeon. Applauded you also for the objectivity of the evidence-based medicine declaration. So it's really appreciated. And
absolutely, thank you.
Which leads me to my question, and that is severity of structural illness. So one thing that we frequently see is patients who in our eyes, and again, I'm biased as a surgeon, obviously, have a very, quote, fixable problem. I'm putting the fixable into serious quotation marks, but something that's reasonably amenable towards a surgical intervention. I assume a moderately severe stenosis or an unstable spondylolisthesis. And they are running around with a stimulator. So where's the boundary of one versus the other? A somatically identifiable problem in a medically reasonably fit patient. Should we just kind of buzz the nerves out of their misery, or should we try to, quote, address the structural problem?
Yeah, I think it's a really complex clinical question. And really, this is kind of where we want to look to your expertise and understanding of the structural issue. Because in your professional and clinical judgment, if there is an intervenable anatomical surgical lesion, I mean, that is obviously preferred. And obviously with patient factor and whether or not that level of structural changes correlate with their pain. I think that's really important. So it all comes down to physical exam and patient selection. So I'm totally on board with that type of thinking. And that's why this collaboration is so important, because if a patient has some of these findings of their spine and they say their finger hurts, and obviously we're not going to operate on that, right? So, but if there is a identifiable lesion that correlates with that clinical presentation, fixing structure in my mind, trumps electrophysiological treatment.
And I want to self-critically point out, our field as spine surgeons is full of surgeons who operate on, quote, structural pathology that we internally disagree with a lot. So this is not like there's just light shining in our fields. There are many concerns about what are good indications and what are not so sensible intervention options. Rod, any questions from your end?
That was a great presentation. I just have a couple questions. What's the reimbursement and how do you guys get approval? Because it seems to me, again, these devices are getting more and more expensive. You know, like the companies, you know, the new, I think I saw the newest version. It's like double the price of last year's version. And then, you know, as physicians, we don't get reimbursed for any of that. And as hospitals continue to kind of clamp down on more, how do you guys deal with that? Like in terms of, are the insurance companies, are there things you have to do before you put one of these things in? Or like, I know trial is something that you guys obviously do from a clinical standpoint, but how is the reimbursement landscape right now?
Yeah, it's a really good question.
Yeah.
I mean, I think it's a problem that is kind of not just obviously in our field here, but in any device-driven field, which is every year industry has a financial incentive to create the newest and best MRI device, whatever the case may be, and want to be compensated for that. And so, it's a huge sort of more of a global providence level issue here. And so, I have sat in on some of the health sort of technology committee meetings, and it really has to do with kind of a priori getting that contract with the device company, setting kind of the price limits and negotiating back and forth about what makes sense in terms of which devices to use. And so that's a very high level question. On the ground clinically, we're mostly looking at individual insurance companies. The state of Washington, for example, doesn't even pay for a trial or an implant. So it's not a covered benefit.
Yeah, that's what I was going to say. I think most, I think LNI doesn't.
Correct. Yeah, correct. And so interestingly, one of my side projects is actually working with a group of physicians to appeal that issue, which is why are we, having sort of this differential treatment of certain patients in terms of the therapies they can receive for pain? Yeah, but that's a really good question.
And how about commercial payers? How are they in terms of?
Yeah, it's interesting. So they're more facile, obviously, but it really depends on the program that that the subscriber buys into. In general, what kind of our interest committees are doing, we're trying to lump these types of therapies all into one thing, which is spinal cord stimulation. So it doesn't matter if it's burst stimulation or high frequency stimulation or DRG stimulation, it's all one type of stimulation. And therefore, for now, can we approve of these devices based upon, all these indications rather than kind of parsing it out into what type of stimulation, because obviously each company will carry their own price tag. So for the time being, it's kind of this smoothed over aggregate effect in terms of negotiating and bargaining, but who knows what that'll be down the road. And especially with more clinical studies showing what type of stimulation works for what type of pain, that's going to change as well. And that's going to make things, unfortunately, probably more complicated. Yeah.
So you addressed something very important that hits us also in spine. That's when industry diversifies its technologies and the nomenclature, it becomes very confusing. Yeah. It becomes very difficult to abstract from a high level what's actually going on. And it makes it very difficult also for third-party payers to kind of parse out what is real, what is not real. So it's an interesting strategy. Maybe it's a good thing because we just don't know yet. Yeah. It's nice to have options, but clearly having more differentiated, more objective pathways would seem to be beneficial.
I agree.
To complicate things more, so Dr. Gupta has been really active in the chat room. He's wanting to know how and what and where the future would bring in terms of motor cortex stimulation versus spinal cord stimulators versus, and here's another thing that we've been excited about in neurosurgery, that's focused ultrasound. So where do you see these kind of general, bigger picture modulations in the neural pathways emanating in the future?
Yeah, it's a really good question. And, my specialty is really in pain. So I'll defer to the expert neurosurgeon in the room for this question in particular with respect to motor cortex stimulation. But we know for certain that there is a huge sort of opportunity here to intervene at a physiological level with these types of technologies. I got a really awesome lesson in anatomy today, just sitting in here. But the physiological sort of components here are really quite missing in terms of our understanding for clinical therapeutics. And so, sort of to answer and not answer the question, there's going to be a huge explosion in the research in various sort of ailments, Parkinson's, motor, just sort of tremors, headaches, other sort of neurological based issues. I mean, you guys probably recently saw in the BBC they published, and this is a really impactful sort of article that really got a lot of people's attention, which is, the use of spinal cord stimulation to get, a person with spinal cord injury who had no motor function back to walking. I mean, it's quite remarkable. So there's a lot of promise that's being held here. And stay tuned. I'm just as eager as everybody else to see what happens.
Yeah, no, this is just the beginning of a lot of interesting things. We had a very cool neurorobotic program that got shut down through COVID here. We would have been probably the first to have this published because it's not FDA approved. Now it's FDA approved, but that's for incomplete patients only. So we're only at the beginning of productive interfaces of our neurons with high energy and electrical circuitry. Well, we really thank you for your honest presentation, for your fascinating outlook in terms of the number of applications. And again, collaboration and interaction is really the key to success here. So thank you for your expertise and your time.
Thank you so much, guys. I appreciate it.
Clinic today. 1 second.
Thanks
I
for
get
coming
off.
over. Yeah.
So thank you for coming over.
Thanks for coming over. Yeah, you too.
So how do you want